Welcome everyone to our Lunch Learn link for February. We have seminars about twice a month during the academic school year, so around a number of cancer prevention and control topics. So we're delighted to bring you a topic from the Center for Health Services Research Cancer Group, and they meet regularly offline, and they have a seminar series as well. And we're co-sponsoring this this seminar today. So we have Nancy Schoenborn from internal medicine with us today. She has worked a good while now on deciphering the world of cancer screening in seniors, and especially those who are older, maybe older than me. You know, a lot of the guidelines are for up to age 70. So the question always is do you want to put your patient through a cancer screening when perhaps their life expectancy is shorter, or they are physically unable to do the test easily, and so forth. So Nancy's really pioneering this work with a number of other researchers here about how do we screen in senior populations. So I ask you to welcome Nancy Schoenborn.
Thank you. Thank you for that introduction, and thank you for having me. And so I'm a clinician researcher. I do geriatric medicine, where I do primary care for older adults, and this is a very common topic that comes up both in clinical care and also is my own research interest, so very excited to share that with you today. I have no conflict of interest, but do want to acknowledge the different funding organizations that supported this research. So cancer is the second leading cause of death among adults 65 and older, and cancer screening, the most common cancer screening in older adults being that for breast cancer, colorectal cancer, and prostate cancer, have been shown to offer the benefit of lowering that cancer-specific mortality and morbidity. However, we're also increasingly becoming more cognizant that, especially in older adults and the ones that have significant comorbidities, screening can also come with harms as well as burdens. And so just a brief summary of the benefits and the harms. The benefits of screening, as many of you would know, is often measured in cancer-specific mortality reduction. And so for colorectal cancer, it's been shown that screening between the ages of 50 and 75 leads to 17 to 24 colorectal cancer averted per 1,000 screened. I would point out that this number is based on repeated screening for that whole 25 years. So the benefit from any single screening is likely much smaller. Similarly, there's also risk reduction with breast cancer mortality, with 7 breast cancer deaths avoided per 1,000 screened. With prostate cancer, that has been much more controversial, where the U.S. Preventive Services Task Force, the current recommendation is against screening with prostate-specific antigen, although they have an ongoing update that is being drafted where they might revert to a C recommendation, which is individualized decision-making for this age group of 55 to 69, because in a large European trial, they did show mortality reduction. So I would say those are fairly well known within the scientific community and has been the rationale behind a lot of public health campaigns to promote screening among our patients. Surveys of both providers and patients have shown, however, that the awareness of harms from screening is much lower than the awareness of benefits. So colonoscopy is the most invasive probably among the screening modalities, where anesthesia can be related with cardiovascular and pulmonary complications, as well as the physical insertion of the scope could cause perforations as well as bleeding. With mammogram, which is a radiology test, or the prostate-specific antigen test, which is a blood test, the risks of the actual screening test may be lower, but they do both have associated fairly high percentage of false positives. And we are becoming more cognizant not only of the downstream tests, which are usually biopsies and more invasive, but also the psychological stress and worry that they may cause in the patients as well. Another concept that's been more recognized in the last decade or so is this idea of overdiagnosis, which means the diagnosis of a cancer that otherwise wouldn't really become clinically relevant in the patient's lifetime, either because the cancer itself is such slow growing that it wouldn't really cause symptoms, or because the patient, him or herself, have such burden of other comorbidities and may really pass away before the cancer can grow to a point of a problem. And so that's been estimated to be a fairly high percentage of the screen detected cancers for breast and prostate cancer that could be classified as overdiagnosis, which of course, once diagnosed, often lead to treatment, which then is thought to be overtreatment, and there's risks and burdens associated with those as well. And so those data really have focused on the magnitude of the benefit and the harms, but we're also becoming aware that when these things happen also matter. So this is a meta-analysis for breast and colorectal cancer that showed it really takes about 10 years before the curves separate between those who got screening and those who didn't, to prevent 1 death per 1,000. And so the benefit, as you can see, is quite delayed from the time the actual screening test occurs. On the other hand, the harms and the burdens usually occur pretty much right away. And so all that is to say, I think conceptually everyone can agree that at some point routine screenings harms may outweigh the benefits. And traditionally when that point has been defined by age. And so this is still the case with the U.S. Preventive Task Force's recommendations, where, for example, for colorectal cancer screening, it's recommended against for 86 years and older. For breast cancer, those 75 and older, they don't really have insufficient evidence to guide us one way or another. And as I mentioned, prostate, we might switch back to a C recommendation, which is dependent on the individual for 55 to 69, and above that is still against. And so we also have learned that age doesn't really tell the whole story in older adults, which is actually the fun part of geriatrics. And so this is work from Louise Walter, where she looked at, on the x-axis, someone's biological age, on the y-axis, someone's life expectancy. The top curve you see is the healthiest 25 percentile, and the bottom curve is the least healthy 25 percentile. And so for an 85-year-old woman, for example, if all we know is her age, her life expectancy could range from 2 to 3 years on that bottom curve to about 10 years on that top curve, which, as we just mentioned, was 10 years being the lag time to benefit for screening could really lead to different decisions for that individual. And so this has been the rationale behind this change in the guideline realm, where life expectancy is increasingly recommended to be considered in addition to age as metric to guide when to stop screening. And so these are just some recommendations from different organizations: American College of Physicians, the American Urological Association, and the American Cancer Society. And so it's an evolving phenomenon, and some recommendations are using both age, like the either age or life expectancy, and some, like the American Cancer Society, have actually removed any age thresholds to guide when to stop screening and kind of have used life expectancy by itself. There's also a lot of Choosing Wisely campaign, which is a campaign started by the American Board of Internal Medicine to reduce overuse, where a number of recommendations have to do with not screening those who have limited life expectancy. Despite these recommendations, this is not the topic to focus on today, but one of the questions that often comes up is how do we know what someone's life expectancy is? And so this was a systematic review from a few years ago that did look at a number of existing validated indices to predict mortality rate up to actually 14 years now. And so just to say that there are existing tools to help guide this prediction other than kind of the gut feeling of clinicians. But many of these older adults are still getting screened. This was a paper from 2014 that looked at 4 different types of cancer screening by their estimated mortality risk over 9 years. So you can see the white bars are the highest risk, where they are predicted to have a 75% or higher chance of dying within 9 years, and yet the screening rate among those people are still fairly high. For example, over 54% for prostate cancer. So even though it does decrease with increasing mortality risk, the absolute numbers in the high-risk group is still fairly high. Arguably, those patients have very little chance to accrue the benefits of screening, even though they're being subjected to the risks. And so my research has really focused on better understanding how both providers and patients think about the decision to stop screening and what are some of the facilitators and barriers. In one of our work with primary care physicians, we did qualitative interviews with a number of them, asking, is patients' life expectancy or prognosis something you think about, and how does that factor into their decisions? And what we found was that many of them often do consider how long their patients might live in their day-to-day clinical decisions, especially in cancer screening. However, there were a number of barriers, and so often it was outweighed if the patient requested screening. So they said, I don't think this person would benefit, but if the patient really asked for the test, I would still give it to her. Another challenge for them was when the patient's biological age was younger. And so one physician said, I would be very hesitant to stop screening in a 50-year-old or a 60-year-old, even though I don't think this person is going to be alive 5 years from now. And so that balance or discordance between age and life expectancy is still a challenge. And then lastly, and this is the part that I'm particularly interested in, is how they communicate these recommendations. So there was really a lot of anxiety on behalf of the clinicians. They felt like using life expectancy as a metric, they felt that they would be playing God. They were fearful that the patient might perceive a recommendation to stop screening as giving up and react very negatively. So that was a main barrier that they said, life expectancy was something I thought in my mind, but it's not really something I verbalized with the patients. And they had a lot of discomfort really on how to talk to patients about stopping screening. And so following that work, and something that I want to focus a little bit more in detail today was 2 projects that we did with patients. Since not a lot was known about this area, we started also with qualitative interviews with older adults, and then we had a follow-up national survey. And so this was individual interviews with older adults living in the community that we conducted in person. We really tried to recruit a wide range in terms of their age, health and functional status, and also predicted life expectancies. We recruited both from ambulatory clinics as well as from house call program that's for homebound older adults, and also this special PACE program that's for dual eligible older adults, so meaning those that have Medicare and Medicaid, so more disadvantaged, but also who are nursing home eligible older adults that being kept in the community. And so try to get both the healthier and the sicker group in our study. And so in the beginning of the study, we give a brief overview of the benefits and the harms of screening, and we explicitly mention this lag time to benefit and why life expectancy might be relevant. And then we asked about their decision making. So, would they ever think about stopping screening, and then what would be the circumstances where they would consider it? We also asked about reactions if their doctor were to recommend that they stop. And then we asked about the idea of individualizing the decision, not only based on age, but also on their health and functional status. And then we tested a number of scripts for explaining stopping screening. So we said, because the risks outweigh the benefits by itself, or also mentioning how old someone was versus mentioning their health status versus mentioning their life expectancy, and asked for their reactions. We actually showed them one of the choosing wisely statements about not recommending cancer screening, and those was limited life expectancy, to get their perspective. And so all the interviews were audio recorded, and we analyzed the transcripts using qualitative content analysis. It was all coded by 2 independent investigators, from which then we derived major themes that I'll show you in a minute. So these were the 40 participants who were part of the study. They had an average age of 75.7, slightly over half were female. More than half had high school education or less. Most were still getting breast and colorectal cancer screening. And to the best of our ability, we got slightly under half that had limited life expectancy, to be defined as under 10 years. About 20% had less than 4 years predicted life expectancy. So these were some of the themes that came out of the conversation. And so we found that at least among these participants, many of them were quite amenable to considering the stopping of cancer screening. They named multiple reasons on their own as to why they might stop screening. The most common was age, but they also mentioned the risks and burdens of screening, if they wouldn't want to pursue treatment, even if a cancer was found, if their quality of life was already poor, or if their doctor recommended it. We found that within the context of a trusting relationship, it didn't really have any negative reactions if their doctor recommended this. Of course, it was a hypothetical suggestion. So one person said, I have all the confidence in my doctor, and if she told me to stop it, I'll stop. Another person said, if the doctor says to me we don't have to do this no more, I say, thank you very much, doc, and I would probably think more of him. And so at least among these participants, the suggestion that they don't continue screening was not viewed negatively, which was very reassuring. We also found that they did support the idea of individualized screening, but they didn't really resonate with the idea of life expectancy. So we asked them, should we consider how healthy someone is and how they function from day to day, in addition to how old someone is in cancer screening? And pretty much everyone said, yes, that's very important. We gave them hypothetical scenarios of a healthy but older person, and whether that person should continue to get screened, and conversely, a sicker but younger person, whether that person should stop screening. And this one person said, don't do it, related to that second scenario. Cancer isn't going to be the thing that kills the people if they've got all those health problems. So they did understand and agree with this idea that these are things that matter. However, even though the participants agreed that age was important, health status was important, and functional status was important, and even though those are the inputs that we use to predict life expectancy in our existing tools, they didn't really equate those factors to be related to life expectancy. So when we showed them the Choosing Wisely recommendation, this was from the Society of General Internal Medicine, pretty much across the board, they reacted fairly negatively. And so this was one person who I think actually demonstrated that she got how we derived life expectancy. She said, how do you actually know the patient is not going to live 10 years? You look at it statistically, I guess, because she has this health problem and this health problem, she probably won't live. And that is how we estimate that life expectancy. But still, even understanding that premise, this person still went on to say, but you never know, there's always that one person who's able to get over the hump. And so didn't really buy into what is recommended in the guideline language. How they prefer to talk about stopping screening had quite a bit of variation. And so the 4 approaches on the left were what we tested. And the reaction was fairly positive. I think more people preferred the one that referred to their health status because they felt that was the most individualized and tailored to them. There were also a subset of people that didn't really want a lengthy explanation, and they perceived having a lot of explanation showed that the doctor didn't really know what he or she was talking about. And so this person said a short yes or no would be okay. They didn't really want to hear about all the uncertainty and the weighing of the pros and cons. Another participant actually didn't feel like this needed to be discussed. So if the doctor wasn't going to give the test to them, he shouldn't have mentioned it. And so it was actually confusing to some of them why it was brought up for discussion if the recommendation was to not do something. And I would say as a side note, when from the work with the clinicians, the omission approach is quite common from the clinician standpoint. And so they often do exactly that, not bring it up. And so when we specifically asked about life expectancy, whether that should be discussed in the context of cancer screening, there was quite a split. So some people said they do want to hear about it because it helps them to better plan and that it's important to be honest and open to share that information. But there were others who didn't want to hear about it, either because they didn't think it could be predicted, so they didn't really believe that doctors can predict life expectancy, even though we did give a blurb about, how we derive that. Others, even if they did think doctors can predict it, they thought it was too depressing. And so there was this really idea that if you think you're going to die, then you're actually going to die sooner. And so they didn't think it was helpful to tell that to the patient. And lastly, we found that the framing and how the phrase is presented made a big difference. And so we had two phrases that reference life expectancy, and to say this test will not help you live longer was much better preferred than you may not live long enough to benefit from the test, which I think is, intuitive when I kind of pair it like that and say it to you. But, from the guideline standpoint, it didn't really have any guidance for clinicians on how to say this. And so from this work, we concluded that they, at least this small group of older adults, were amenable to consider stopping cancer screening, especially when they trusted their doctors, but didn't really recognize the relevance of life expectancy in that decision. And they were very much influenced by the framing. And so we went on, because that was such a small sample, to generate hypotheses. We went on to do a larger survey to test some of the findings. So this was a cross-sectional survey where we partnered with school public health faculty to use stated preference methods to understand older adults' preferences. So we used an online panel that is the largest in the U.S. They have over 55,000 panel members, and it is based on probability-based sampling, so it's not a volunteer-based panel. They do offer internet and or computer access for those who were selected to be part of their member who don't have access to those, to improve their generalizability. And so we had a fairly broad inclusion criteria, so really anyone who's 65 and older and could complete the survey in English. A subset of those were invited to participate over email, and males were randomized to questions about PSA versus colonoscopy, and females were randomized to mammogram versus colonoscopy. And so we used this technique called best-worst scaling that came out of health economics, where that allowed us to quantify the strength of their preferences, which is not really possible with Likert scales. And these were the explanations that we tested. So we set up the premise that it may not be appropriate for some people to get another screening test. And if that's what the doctor wants to recommend, which of these explanations sounded the best to explain why they shouldn't get another screening test? And so is it because the guidelines say you don't need another one? Is it because of their age, life expectancy, because of quality of life, or their other health issues? We also had explanations related to the screening test itself. So is it the benefit or the harms, the inconvenience or the discomfort? And we also included those two omission ones that we derived from the qualitative work. So either giving a recommendation, just yes or no without an explanation, or not bringing it up at all. And so we constructed 13 choice tasks. This was an example of one where a subset of 4 is shown at a given time, and the participant is asked to choose one best explanation and one worst explanation. They do this repeatedly. And so this data was collected after very extensive pilot testing in November of 2016. And so we had 881 participants who completed the survey, which was corresponded to a response rate close to 70%. So slightly younger than our in-person qualitative work, with an average age of 73. Again, slightly over half was female. Slightly under half was high school education or less. And then about 2/3 were still getting cancer screening according to guidelines. And then here only about around 1/3 who had limited life expectancy. So overall, a little bit healthier than the 40 people we interviewed. And so how we analyzed the best-worst scaling data was we first just counted how often each one was chosen as best or worst, and then that was translated into a standardized score where -1 was the least preferred or the worst, and then +1 was the most preferred or the best. And we also stratified by both screening type and their age. So this was what we found. The most preferred explanation with a standard score of 0.41 was talking about other health priorities. So saying you don't need another mammogram or colonoscopy or PSA because we should focus on your other health conditions was the most attractive. Guideline actually was the second most preferred overall. And age, talking about risk and benefits, were also in the top. You'll see would not help you live longer is about in the middle with a score of -0.01. That you may not live long enough to benefit was the second to last one. Talking about discomfort or inconvenience of the test usually was less convincing or preferred for the participants. And they also did not like giving no explanation or not bringing up the discussion at all. When we stratified by screening type, there basically ran separate models for each of those. It didn't really show too much difference. And this slide is a little busy with a lot of numbers, but I want to focus on the ranking. So with the aggregate data on the very left, breast, prostate, and colorectal cancer screening, you see that the most preferred top 3 or 4 are about the same. Talking about other health priority was the most preferred across different cancer types. Similarly, those on the bottom are also essentially unchanged across cancer screening types as well. Next, we stratified by age into 3 age groups. So 65 to 75, 75 to 85, and 85 and above. And so here, we had the least number of people in the 85 and above group. But for them, their most preferred explanations was guidelines, followed by age. That was probably the most noticeable difference when we did the stratification by age. And so that study did have the premise based on hypothetical scenarios, so that is a limitation of the study. Most of the participants were fairly healthy, and so there is that caveat how well they can put them in the shoes of stopping screening when that probably wasn't applicable for them in real life. And for the methodology really only allowed us to test mutually exclusive phrases versus I know in my own practice, the doctor is probably likely to mention more than one reason in the discussion. So that was something that we couldn't really study as well. But this was the first study, to our knowledge, to really look at patient preferences for how to communicate stopping screening and talking about other health priorities, guidelines, and the benefit and harm seem to be more preferred. And I would say mentioning other health priorities being preferred also did come out of the qualitative work. It was actually one of the suggestions that the participants made when we asked that, you know, how can doctors talk about this? Because that they said that made them feel like they were still doing something. So the care was not removed, that they were not receiving less care. So that did resonate both in the first and the second study. And so again, life expectancy was not a preferred explanation, nor is omitting a discussion about this. So that's very interesting because both in our prior qualitative work with the clinicians and in other studies in the literature, we do know that clinicians often do omit a discussion. I mean, understandably, it is very busy, especially in primary care, and so they don't often bring up something that they're not going to do. And so here, the patients actually did not really prefer that approach, and so it does raise an interesting dilemma on how to really approach this. Should a discussion be initiated regardless, even if the recommendation is to stop? And hopefully this can directly inform what clinicians do in their communication practices. But certainly an online panel, even one that is probability-based, may not be representative of all older adults, especially we worry that those with low health literacy or low computer use, this result may not generalize to them. And so it does need to be tested in other populations. And so in summary, I think it is important to not only think about the magnitude of the benefit and harms, but also the time frame of when those benefit and harm happens in the context of cancer screening. And that is the reason why life expectancy, along with age, has been advocated to be an important factor to consider when we individualize screening decisions. And we do have some emerging evidence, hopefully more coming in the pipelines, on using patient preferences to really inform what we do, especially how we communicate with patients in routine practice. And so really want to acknowledge a lot of team members that supported me through this work, and hopefully we'll have plenty of time for questions.
Okay, thanks so much, Nancy. We have time for questions.
Where does the insurance reimbursement fit into this, into these recommendations?
That is a great question. And so I believe, not being an expert on insurance coverage, and so there is not a denial of coverage at any age. So it's not like the insurance will stop covering mammograms or colonoscopies altogether. I do think under the ACA, those recommendations that's an A or B, so the higher level of evidence supporting them from the U.S. Preventive Task Force, are probably covered without any copay. And so for those who go beyond those, they probably have what typically a 20% copay for those procedures, but 80% is still covered, even if they're 90, 100, or however low.
So it seems to me that the critical issue, or one of the critical issues here, is how you determine the expected life expectancy. Do you consider competing risks in that, or is it just general health of the patient? In other words, if someone's at high risk for cardiovascular disease, does that go into the formula where you calculate life expectancy?
Yes, that's a great question. I would say that state of science is also still growing. So we have several validated indices. Some are claims-based, where they only use age and comorbidity information from administrative data like Medicare. There's two that are survey-based, using self-reported health and functional status in addition to age and kind of demographic information. I would say there was a study where we did and looked at the concordance among the four, and it was good but not great, I would say, is the bottom line. So there is some degree of concordance among all the prediction models. And I would say they do implicitly probably take into account competing risk because of how that would have affected their function, I would think, especially in the self-reported ones. But I would say, in full disclosure, they're not where we want or need them to be. I think in the guidelines, it's very vague in some of them, that they don't name a threshold. So they just say, if patient has limited life expectancy, don't do this. But they don't really say what limited life expectancy means. Some other guidelines that do mention a threshold have usually chosen 10 years. usually because the meta-analysis showed that 10 years is the time to benefit for these screening tests. However, even with that, it's a little bit simplistic, I think, in my mind. So what these prediction models give is really a confidence interval of mortality within a given time period. So 10-year mortality might be 52 to 58%, right? So any model is going to have some inherent uncertainty. And so I think that uncertainty is lost or kind of ignored a bit when we translate it into a point estimate of median life expectancy. And I don't think the guidelines adequately address that. So what if someone's median life expectancy is 9.5 years? Is that, close enough to 10 years? Are we sure it's really not going to benefit this person? I think it's much easier when, they're got 1 or 2 years of life expectancy, and it's very different, that they're probably won't be much overlap. That's much easier. But when they're closer to the border, I don't think that's really fleshed out yet. Sorry, that's a long answer to your question.
Did we have a question over there? No. Okay. Over here.
I've heard that life insurance companies have the best life expectancy tables. Have you?
Thank you for bringing that up. So they're all proprietary, so I don't know how good or bad they are, but it is interesting that, when we talk to clinicians, there really is quite a lot of anxiety in how they approach this and how they bring it up. But in a totally different field, prognostication is done with no apologies and not really much explanation, right? So, a person might go and they say, well, here's what we think your life expectancy is. They don't really explain how they got that or how confident they're in that estimate. But because of that, here's the policies that you would qualify for. And I don't think patients really react to it in the way that we might expect them to react and so it is interesting to think about how public patients approach that information versus the information they get with physicians. But no, I don't know how they calculate theirs.
Nancy, I know there are some variations in screening, and you've presented for the breast, colon, and cervix, as well as prostate. Could you talk a little bit about cervical and then about prostate? Because the guidelines have morphed and incorporated some of these ideas already, and how do you see that evolving?
Yeah, I would say I haven't thought about cervical as much. So the guidelines I understand is as long as they have had negative PAPs prior to turning 65, has several of consecutive negative ones, then screening stops at 65. And I think different than these other types of cancer screening, that is not entirely based on competing risk, but I think also has to do with the biology of cervical cancer specifically. And so in my clinic, which sees 65 and older, it's usually a non-issue. I would say prostate cancer screening has probably been the most controversial. Maybe now lung cancer is also getting up there, where they initially said don't screen in 75 and older. That was the guideline with the U.S. Preventive Services Task Force in 2008. And then they changed to no screening for any age in 2012. And then now they might change back to okay to screen 55 to 69. And so that's where I think there's different language across guidelines from different organizations. And I think it's really confusing for patients, right? So from their perspective, they there was a conference on preventing overdiagnosis that had a lot of patient advocates come and share their perspective. And really from their perspective, it's very disconcerting to see that an authoritative source for health recommendations is changing so much. So something was good, you should do it, and then now, no, you shouldn't do it, and maybe, well, you should do it. And so it is difficult for them to really know what to do with it. And a lot of people say, well, if the experts can't even agree, what can I, how can I make a good decision? And so that is still hotly debated, I would say, for prostate cancer, especially for that middle age group, where I think large trials have shown kind of conflicting data. But I think practically, it does have an even longer lag time to benefit, I think around 13 years compared to breast and colorectal. And the absolute risk reduction, even if it does exist, is probably the smallest. So I think it's worthwhile to have a discussion to think about if this is abnormal. Do you really want to go through the biopsy? What would you do with that information? Let's not just automatically order it because we're getting blood work for something else today. But some people are still adamant about getting that. So there is still that.
Nancy, I see a couple of epidemiology types over here who have looked at cervical and prostate cancer. I wonder if either of you would want to add. I see a slow head wag.
Yeah, I mean, I haven't played with this in about 25 years, but I really think that for women who have had cervical cancer screening throughout their life, ceasing screening at 65 or 70 certainly seems not to carry any real adverse outcome, given the lengthy time for most of the cancers to develop. But frankly, sleeping well at night is also good, and so. I'm not sure. I'm not an expert on prostates.
Thank you. Michelle, would you want to comment on prostate cancer screening policy?
Thank you. I think I like the life expectancy issue, especially at my age. But life expectancy, as you well know, is computed on an aggregate. And the future of a cancer to kill someone also based on an aggregate. So how do you reconcile, on a population basis, you can make recommendations quite easily, like if the cancer kills before life expectancy, then you do it. If it doesn't, you leave it alone. But how do you reconcile the results based on aggregates to deal with this specific patient? Like, it's me, and the aggregate may not apply to me. How do you deal with the population versus clinical decision making?
Yeah, no, that's a great question. I think that's what that one quote from a participant mentioned, right? There's always that one, and I could be that one. And so I think I always say that we cannot predict exactly for any individual, right? And so recognizing that uncertainty and have the humility that we don't really know exactly. But I think the evidence is there to guide us. So if in general, 90% of people similar to this person would have died in 5 years, yes, this person could live to 15, 20 years, but that's fairly unlikely. And so I think I never make a decision without their input, right? So it's always shared. And so I tell them what I'm worried about. I think another thing that's under-recognized in the most relevant group, not only older, but quite disabled and have so many other, not uncommonly, I have patients who have 10, 12 active medical problems to deal with. They're homebound and have a number of functional issues. And I know that between this visit and next visit, they can just get one thing done, if that. And so if I push them to get that mammogram, they probably won't go see the nephrologist or go get physical therapy for their fall prevention. And so it's also a prioritizing scheme. So what I say is here's the harms that could come. It has a small degree of benefits. Is this something you're worried about? And how would you feel about not getting another one anymore? And so I think it's okay to make a recommendation within the context of shared decision making. It doesn't mean that I gave them the menu and they pick. I do give them guidance, but it is a decision that we make together. And so there are certainly patients who are very adamant about continue to get screened, even though I don't think it really is going to help them. And they demonstrate that they understand what the harms could be, and that's what they choose. And, some of the benefit of reassurance, these subjective qualities, it is difficult to quantify. And so for someone who is deathly afraid of cancer, who am I to say that the benefit as measured by mortality per se, she may perceive and actually derive a bigger benefit than what studies can measure. And so I do try to tailor it, but I think for a lot of people who are quite happy not to do it again, especially I don't think I have any patients who's jumping up and down to get colonoscopies. Like the permission that they could potentially stop is actually very welcoming.
Thanks so much again, Nancy. We'll adjourn. There's pizza outside in the gallery. And if you have any questions, just come up here. We have a couple more minutes in the room, so you can ask Nancy your questions then. Let's give her another hand.
Thank you.